So my talk will be on the single inhaler triple therapy for COPD. As we all know, COPD is very common and day-to-day practice we encounter such kind of patient. But for particular group of the patients of COPD, now there is novel therapy in the form of single inhaler triple therapy is available. We will be running through some clinical discussion, then some real life evidences, and what will be the utility of this molecule. So as we all know, according to the definition of COPD is a common preventable and treatable disease, which is characterized by chronic respiratory symptoms and or associated with alveoli, which causes persistent and often progressive airflow limitation. Important thing is that COPD is almost every time associated with history of recurrent lower respiratory tract infection and history of exposure to various risk factors. Coming on to the global burden of COPD, almost 212.3 million cases occurred every year, out of which almost 37.8 million cases are in India. Coming on to the COPD burden in India, it causes high morbidity and high mortality. In India, we encounter disproportionately high burden of chronic respiratory diseases, which accounts almost 1/3 of the total global daily, and 75% of these cases are for COPD alone. In India, COPD is usually largely underdiagnosed, undertreated, and it often presents in advanced cases. Also, COPD is associated to affect almost 7% of Indian adult age greater than 30 years. According to the GOLD guidelines, the prevalence for COPD group D patient is almost 12 to 27%. For group E patient, it accounts to even more, almost 29 to 42% of the cases. Also, in Indian scenario, the high eosinophil count is also common, and often we know COPD is patients have multiple comorbidities. Therefore, the highly symptomatic and exacerbation in this group of the COPD is quite common for group D and group E. Whenever we are managing COPD in India, we often encounter various gaps and challenges in the form of there is discrepancy in the diagnosis, lack of proper labeling. Asthma is labeled as COPD in first OPD encounter, in second encounter the diagnosis changes. Therefore, the appropriate management of the disease gets changed. Often it is underdiagnosed or incorrect diagnosis, poor management, and still we encounter the widespread use of oral therapy in the form of oral corticosteroid, the thioestelin tablets. But non-smoking related risk factors in India are quite common, likely childhood lower respiratory tract infection, the biomass exposure, prior history of tuberculosis, environmental pollution, and high burden of ACOS patients also, plus the negative influence by the certain cultural and social beliefs are still common. Why this group of COPD is important? Because as we see, whenever patient encounters first exacerbation, there is 37% faster decline in their lung function. Also, whenever patient encounters exacerbation, the frequency and severity, the proportion of death will increase according to the increase in the frequency and severity of the exacerbation. Whenever patient of acute exacerbation of COPD encounters, the cardiovascular risk factor is also increased. Therefore, to manage such cases, the GOLD guideline have defined in 3 groups, and we treat patients on the basis of their symptoms and exacerbation history. What is the primary objective? Whenever we want to treat COPD, the primary objective for managing this patient, we want to reduce the symptom burden, we want to reduce the disease progression, we want to reduce the risk of exacerbation, and also we want to decrease the mortality. So do we have any molecule which can accomplish this primary objective? Currently, the available COPD therapies in the wide form, in the form of some oral medications, the inhalers are available, the xanthines are available, the anticholinergic drugs are there, and leukotriene antagonists are also there. So what GOLD guideline says? The GOLD guideline says that the initial pharmacological management for group B patients should comprise of LABA plus LAMA, and for group E, they have said that whenever the eosinophil count is more than 300, we have to consider LABA, LAMA, and ICS also. GOLD has also said that the single inhaler therapy may be more convenient and effective than multiple inhaler therapy, and single inhaler also improves the adherence to the treatment. So these are two group of the patient. First patient is 65-year male patients we having COPD since last 6 years, currently symptomatic despite on dual therapy, history of severe exacerbation, active smoker, eosinophil count is 200. Second patient is of 70-year-old female, breathless on exertion. Patient reports frequent healthcare visits elsewhere, treated with short course of antibiotics, steroids and relievers, and diagnosed at COPD at current visit with FEV1 of 45% predicted, CAT score of 20, history of MI 4 years back. So for such group of patient, do we have any therapy to manage? So what our Indian guidelines said. So there was one Indian medical expert review in which they have said that use of single inhaler triple therapy in the management of airway disease should be encouraged, and it should be used to manage such kind of cases. Why they have said that? Because there are certain advantages with this single inhaler triple therapy. The various systematic review and meta-analysis have said that there are benefits of triple therapy over dual therapies in the form of reduction of exacerbation, improved lung function, improved quality of life, acceptable safety, and reduced mortality risk also. Also, it offers the reduced treatment complexity, better adherence, improved outcome in advanced stages, and it also improves outcome in various COPD phenotypes like COPD eosinophilic phenotype. So what are the current approved treatment? Nowadays there are various single inhaler triple therapies are available in the market. In initial days, the landmark trial, which have the various landmark trial for COPD done with the Trilogy Ellipta molecule. We have glycoLab molecule, the glycopyrronium ARZ-FF molecule is also available, and various companies are coming with various molecules. So today's molecule of discussion is fluticasone furoate, umeclidinium, vilanterol, and it has been engineered for the longer 24 hours duration, consisting of ICS reducing the inflammation, LABA which promotes the bronchodilation, and LAMA inhibiting the bronchoconstriction. So we are having a molecule which runs in a synergisty and gives a complete 24-hour protection. As we all know, the umeclidinium is a selective M3 muscarinic receptor. Vilanterol selectively acts on beta-2 agonist group, and fluticasone furoate helps in the reducing the inflammation. So what are the distinct pharmacological values with this molecule? This molecule is usually used in the doses umeclidinium 62.5, vilanterol of 25, and fluticasone furoate of 100. Umeclidinium gives a unique idea of a slower speed of dissociation from M3 compared to the M2 receptor. Therefore, it gives a prolonged offset action. Vilanterol is rapid action and high selectivity for beta-2, while fluticasone furoate is potent in inhaled corticosteroid, having low dose, low oral bioavailability, and low systemic exposure. Why they have choose fluticasone furoate? Because it has high and good receptor binding affinity, almost ranking higher than various other molecules which are available, and absolute bioavailability in the tissue is very less. Therefore, it gives a low therapeutic dose, which in combination with its low bioavailability reduces the potential of systemic effects compared to the other inhaled corticosteroid. While coming on to the vilanterol, it has faster onset of action of 5.8 minutes. Selectivity for beta-2 receptor is almost 2400, and dose interval ratio is for 24 hours. For umeclidinium, it helps in increasing the rapid increase in the FEV1 value of the patient, giving a systemic and sustained bronchodilation, almost increase of greater than 100 ml improvement even at the end of 24 hours has been noted. So do we have evidence for this molecule? The answer is yes. There was one impact trial which has been done for almost more than 10,000 patients, which was a phase 3 randomized double-blind parallel group multicentral trial. Primary objective was to assess the rate of moderate and severe exacerbation for oral once a day single inhaler triple therapy versus once a day dual therapies. So these were their inclusion criteria: ex-smoker, patient of age more than 40 years, post bronchodilator FEV1 less than 50, Patient having one or more moderate or severe exacerbation, use of ICS or LAMA or LABA in combination for 2 weeks, and CAT score greater than 10. So what were their findings? On the basis of impact trial, it has been found that this group of patients of moderate or severe COPD patient, they all patient had history of exacerbation. Whenever this molecule has been used, the exacerbation rate have been decreased. So what they have found, there was 25% reduction when this molecule was used against the combination of LABA and LABA, and 15% more reduction when it was compared with ICS and LABA. Also, impact study has also showed benefit for the one exacerbation subgroup also. Patient having single moderate or single moderate subgroup exacerbation, they have found that it has reduced their exacerbation. Plus, it also significantly reduces the severe exacerbation which was requiring hospitalization, 34% reduction when compared with LABA and LABA, and 13% reduction when compared with ICS plus LABA. When they studied the lung function values, they have found that the impact trial, given there was significant increase in the FEV1 value by 97 ml. And when they compared the quality of life, there was greater and more improved in the quality of life of the patient. When the risk of mortality was studied, in the impact trial, they have found that there were 42% reduction in the risk of mortality. Also, it was quite safe when it was compared to the other dual therapies, whatever available in the market. And it has also reduced the cardiovascular safety was there. So we have a molecule which is giving 25% reduction in the annual rate of exacerbation, 42% reduction in the all-cause mortality, 97 ml increase in their TRO FEV1 value, annual rate of hospitalization have been reduced by almost 34%, and 1.4 times increase in the quality of life of the symptom. Do we have another study to study the comparable effects of impact trial? The answer is yes. The fulfill trial was also done when it was compared with ICS and LABA, in which they have found that the similar effects were found. Increase in the FEV1 by almost 171 ml in fulfill trial, increase in the quality of life, and 35% reduction in the severe exacerbation. But what about adherence and persistence, and what about the outcomes? So for adherence and persistence, one study was done in Germany, in which they have evaluated the adherence and persistence to triple therapy at the interval of 6 months, 12 months, and 18 months. And they have found that there was higher adherence and persistence for patients on this single inhaler triple therapy versus multiple inhaler triple therapy. And one study which was done in Spain, in which they studied it was published in Chest journal, in which they studied, do patients in COPD in Spain have improved outcomes when the single inhaler triple therapy was used against the multiple inhaler triple therapy. And they have found that whenever patient initiated on single inhaler triple therapy, they had clinical relevant improvement in persistence, leading to the reduction in mortality, incidence of exacerbation, and healthcare resources used as compared with multiple inhaler triple therapy. Now coming on to the outcomes with either a prompt initiation of this agent or a delayed. Prompt initiation means patient had a episode of exacerbation and within 30 days you have initiated this molecule, or a delayed initiation after 30 days of their exacerbation history. So on this study, they have found that whenever the prompt initiation of this molecule has been done following either a moderate or severe exacerbation, it was significantly associated with significant reduction in their exacerbation and healthcare costs relative to the delayed initiation. Therefore, as we have studied, the goal of our COPD management in relieving the symptom, improving the exercise tolerance, improving the health status, directly affecting reducing the symptoms of patient. We have a molecule which is giving almost 1.4 times reducing the symptoms and reducing the risk of reduction in their exacerbation, disease progression, and mortality compared to the 25% reduction and 42% reduction. Therefore, nowadays or in future, we'll be seeing the initiation and use of the single inhaler triple therapy in managing COPD in our diverse country like India. That's it. Thank you.
That is very informative talk, Dr.
Thank you.
Parikshit. Is there any comparison between imeclidium and glycopyrronium, which is superior?
As such, there are no studies have been done with two molecules, because in various combination these molecules have been used, and the various the devices which have been used for these molecules are different. The impact trial in which they have used a molecule of uh, Ellipta, which uses a different technology, and in our condition, in our country, most of the times we are using the Rotacaps inhaler. So there is future scope for research on this molecule, so that we'll have a better idea in country like ours.
Any question?
Nice presentation, Dr. Parikshit. My question was, dual therapy is obviously inferior to the triple therapy, but there are any trials in India where regarding the adherence, where in Spain trial, the adherence were apparently better with multiple inhaler giving triple therapy,
Yes.
or a single.
No, sir, I have not found any.
Another
research.
thing, about how the patient perceives the disease. है ना?
Yes.
For example, if I give single inhaler, patient might perceive it as not that serious disease.
Yes.
Whereas if I give multiple inhalers, patient understands, okay, the disease is severe. That's why I'm taking, 3 or 2
Inhalers.
compared to one. So any study, any research on that? How do, especially Indian patient, how they perceive their disease? Because the problem with COPD is how they perceive the disease.
Yes.
If they perceive the disease as severe, the adherence is likely to improve.
Yeah.
So anything?
No, as such, no data is available in literature for Indian population. In impact trial also, there were hardly 500 to 1000 Indians of population candidates were taken. There is, I think, we need more research and data for this thing.
So to counsel the counseling is our part.
Yes, sir.
So we have to counsel the patient. We have to show the spirometry report to the patient that your FEV1 has gone down so dramatically, and there is one parameter is there, ELA is there. So estimated lung age. Suppose the patient's age, actual age is 60, suppose, and the spirometry is showing 100 here. So you can show that, see, your actual age is.
Problem is even the physicians, they don't understand spirometry. How will the patient understand the spirometry?
But that parameter will be helpful for you us
Yes.
also.
I think the adherence mainly in our Indian condition depends on the symptoms. As soon as patient starts feeling better, they give up their therapy. Therefore, it is very important if we are encountering such group of the patient or group B or group C, if we counsel them properly and initiate from begin to start with single inhaler triple therapy, which will give a good result, then I think the adherence point can be taken care of. However, it is very diverse in our whenever patient get referred, they are actually COPD patient but labeled as asthma at somewhere else. Then again they get admitted at somewhere else. Their diagnosis changes, the adherence changes. Patient have the asthma COPD overlap factor also. Therefore, it becomes slightly difficult in our population setup. But I think as a chest physician, the counseling is the most important factor, and if we counsel patient properly, it will give a good result.
Sir, any study where are showing a COPD patient with comorbidity like a CVD? So dual therapy firstly started. You are a dual therapy or triple therapy, and what is the role?
I think if you are encountering patient for first time, then you can initiate on the dual therapy. But this group of patient, if they are encountering more and more exacerbation, then that is the time you should shift to the single inhaler triple therapy. Even if single inhaler triple is a novel concept, previously we used to add tiotropium to this group of the patient, which used to give a good result. So no, as such, only in impact trial they have shown that the patient having cardiovascular risk factor that has also been reduced with single inhaler triple therapy.
Sir, whenever you started triple therapy, COPD with the CVD patient, any study shows death rate so reduces?
No, only the data of impact trial is there, and there are 1-2 trials that have also shown.
We can take only one more question because we are running late. Dr. Vikram, please.
Wonderful talk, Dr. Parikshit. With the availability of SITT once a day advantage and adherence, do you feel it is like getting misused or overused? And how
Yes.
can we tackle it? I mean, at our level.
Overuse is a quite big problem in country like ours. Whenever a new molecule come, directly it will come to prescription. I think the selection of the patient is very important. Whenever we are having uh, uh, tools available, spirometry, patient's history, patient's exacerbation, if we select the patient properly of group B and group E, in this group of the patient, the single inhaler triple therapy will be helpful. Most, yes. I think that is going to be that was problem of the past, problem of the present, and it will be there. It is very difficult to tackle, I feel. That's it.
Thank you.
Thank